So, welcome to our 20th live webinar on orthopedic principles. This time we have distinguished faculty, Dr. Amar Abdelgawad from New York. Dr. Amar Abdelgawad is an attending orthopedic surgeon in Maimonaides Medical Center, Brooklyn, New York. He is certified by the American Board of Orthopedic Surgeons. He received his medical degree, master's and PhD in orthopedic surgery from Ain Shams University in Cairo. He obtained an MBA from Walden University in October 2017. Dr. Abdelgawad is a fellowship trained in pediatric orthopedic trauma and limb lengthening and reconstruction. He's a member of the American Academy of Orthopedic Surgeons, Orthopedic Trauma Association, and the Pediatric Orthopedic Society of North America. Dr. Abdelgawad is the main editor of Pediatric Orthopedic Handbook for Primary Care Physicians, a very successful handbook used by primary care physicians, nurses, therapists, and medical students. He's the author of the book, The Guide to Pass the Final Orthopedic Exam, a concise review for orthopedic board exam. An outstanding textbook used by many residents in their study for orthopedic board. His channel, Pediatric Orthopedic, is the most popular pediatric orthopedic channel on YouTube with more than 10 lakh hits and more than 10,000 subscribers. This channel gets positive reviews from all over the world. Dr. Abdelgawad wrote more than 110 papers and book chapters. His work has been cited more than 920 times. Dr. Abdelgawad described a new technique for treatment of Blount's disease, a new method for intramedullary nail extraction, a new technique for obtaining bone graft, a new technique for fixation of the calcaneal tuberosity, and a new method of fixation of pediatric distal femur fractures. Dr. Abdelgawad also has 3 patents to his credit. So today it's my honor to invite Dr. Amar Abdelgawad from Brooklyn, New York, to talk on pediatric femur fractures. Over to you, Dr. Amar. You can share your screen.
Thank you, Dr. Gopalan. It's my pleasure to be here in the webinar for Ortho Principles. I'm going to talk about one of important topic, both in trauma and pediatrics, the pediatric femur fractures. I think it's an important topic for pediatric orthopedic and for traumatologists and also for general orthopedic surgeons who take cold. The objectives in this, we're going to go quickly on the epidemiology, anatomy, and pathology. And then we're going to speak about the general management. After that, we're going to speak about the fractures due to child abuse. And then we're going to go to the fun part that we're all waiting for, is the treatment options for the shaft, proximal, and distal femur fracture. We're going to speak about the advantage and disadvantage of each treatment option. So quickly, the epidemiology, femur fracture is one of the common long bone. It's after the forearm tibia. It's about 1.6 of the children fracture. So it's about 30 in every 100,000 child per year. So if your city have about like 500 child, you expect to have about 150 of this a year, mostly in males and mostly above the age of 3-year-olds. The mechanism, if you have first to exclude non-accidental trauma. We're going to show a few slides on that. For the very young children and toddler, it's usually fall. Between 3 and 10-year-old, it's usually stuck by a car. Sports in the adolescent, and of course, motor vehicle crashes in every age. If you can see here in the middle picture, this is the kids between 3 and 10. Their size, their length will make the car bumper hit their femur and get femur fracture together with head injury and abdominal. Usually the older children will get tibia fracture, and the small one, they get abdominal injury and head injury, as you can see in this picture. So the physical exam, I always tell people that femur fracture is something major. You have to have a major trauma to get a femur fracture. So you have to consider your trauma guidelines, the ABC, the airway, breathing, and circulation before start looking into the bone. You have to examine the head, chest, abdomen. So you have to get your traumatologist colleagues to help you, because femur fracture is not an easy fracture. You have always to document distal neurological and vascular status, especially with distal fracture, as we're going to show some examples. You have to palpate old bone. The femur fracture is what we call distracting. What does it mean, distracting? It means the pain from the femur is so severe that if the patient has another injury, he may not tell you that he has pain from it. Like this, one of my patients, adolescent patient, as you can see here, there is a growth plate. He has a femur fracture, so all he's complaining is his thigh. But if you examine him and you palpate the left arm, he will have some pain. So X-rays shows it has also a humerus fracture. And then you apply after you do the ABC, you examine, you splint or put the patient in traction. Radiological evaluation is very important. You have to see the AP and lateral, and this has to show all the way from the hip to the knee, as you can see here, AP and lateral showing all the way from the pelvis from the knee to the hip joint. Remember some of these fractures, as you can see here in this picture on the left, there is a femoral neck fracture together with a femoral shaft. So you have to get good X-ray. And it's also recommended that you get pelvis X-ray. So if you have a femur X-ray, a femur fracture, always get a pelvis X-ray. Make sure you can see the pelvis very good. Make sure you can see the femoral neck so that you don't miss a fracture. Now we come to the classification. So you can classify femur fracture either open or closed. You can classify them according to their location, anatomic location. Is it proximal? Is it diaphyseal or distal? And the distal, we go through physeal and metaphyseal, as we're going to see in this lecture. And then the fracture pattern, transverse, spiral, oblique, comminuted, green stick, all these are different fracture patterns. A few slides on non-accidental trauma or child abuse. This is one of the femur fracture is one of the fracture that is very classically described with child abuse. I want to say it's not easy to recognize non-accidental trauma. We think that non-accidental trauma is rare. It is not. It's actually much more common than we expect. 1% of children are abused each year, which is in the US alone, it's about 1 million. And child abuse is the second cause of mortality in infants. So it's something that you have always to keep in your mind. Children in all ages can be abused, all socioeconomic. It's not for only patients with a specific socioeconomic or background. It's for every socioeconomic, every background. Children can have child abuse. It's very important to know that 65% of cases of child abuse come with isolated bone fractures. So you as an orthopedic surgeon has a great responsibility to detect these kids. Why it's that important? Because if you don't recognize that this is a case of child abuse and you let the child go home, there is a 5% chance of death later on, and 25% chance of another serious injury. So you have to recognize this. You have to put the child in a safe. How do you diagnose a non-accidental trauma or child abuse? It's mainly history. It's not the type of the fracture, as I'm going to show you. It's the history. So if you get a history inconsistency of injury, like the child was walking and then he broke femur and humerus, that doesn't make sense. Also delay in presentation. They come, you get an X-ray which show colors, so that means that the fracture has been going on for 1 week. Why didn't they come in that 1 week? If they report mechanism of injury insufficient to explain the injury, as we said, and if it's changing. So if the mother tell you something, the child tell you something, the brother tell you something, the father tell you something, the stepfather tell you something, that will guide you that there is something wrong. Why is the story is changing between people? If the parents are hostile or indifferent, all these are red flags for non-accidental trauma. So in specific non-accidental trauma and the femur, any femur fracture in a child that is not walking, which is usually happening around the age of 12 to a 16 month, is a big red flag. So if you're not walking, you should not get a femur fracture. So this is one of my patient here. He's 6 months and he gets a femur fracture. So this is a big red flag. That's child abuse. We did bone survey and found also he has a clavicle fracture. This was a case of child abuse. We put him in a cast. What about spiral fracture? Everyone talks about spiral fracture. Non-accidental trauma or child abuse is a spiral fracture. Actually, that's not correct. There is more spiral fracture in accidental trauma than in non-accidental trauma. So like a real trauma will get you spiral fracture more than child abuse. And only in cases of child abuse, only one third are spiral fracture, the rest are non-spiral fracture. Now let's go to the anatomic classification that we talked about. There is proximal femur fracture, diaphysis, and distal fracture. And we're going now to go to the common one, the diaphyseal fracture. So diaphyseal fracture, we talked about the history, we talked about how to manage. Don't forget the ABC, airway, breathing, and circulation. That's much more important. You have to focus on this before focusing on your femur. You have, again, to look for all the other bone. The child may have another fracture, but he's distracted by the femur fracture. So there are 6 methods of treatment that we're going to talk about, which covers the treatment of the shaft fractures. 2 of them are the non-surgical and 4 are the surgical. The 2 non-surgical are the Pavlik harness and the hip spica. The 4 surgical are plate and screws, external fixator, flexible nailing, and rigid nailing. So for kids that are less than 6 months, so if you have a child like 4 months, there's like this child, he has a femur fracture, or sometimes, you know, the femur fracture happens as the birth injury. You can put them in Pavlik harness. You don't need to put a spica cast for them. You can just put them in a Pavlik harness. So this is one of my patients. He was very young, so we put him in a Pavlik harness. And they heal very good, and they are not in too much pain. After a few days, they will be okay. So kids that are less than 6 months, you go for Pavlik harness. If it's a birth injury, also go for Pavlik harness, and that should be enough. Now let's go for the spica cast. So what is the spica cast? Spica cast in which you apply the cast for the involved extremity and half of the other extremity. It is a good method of treatment for children up to the age of 4-year-old. After 4-year-old, it becomes a little bit hard to take care of the child, and it's not as easy. You can still apply it, but it's not easy. So I usually use a spica cast till the age of 4-year-old. We call what we say immediate spica cast. So when I was resident, we used to put this patient in the hospital and do traction for 1 week, or put them in traction and then ask them to come after traveling traction, ask them to come after 1 week to do the spica cast. You don't need to do that anymore, especially if you're doing it only for children that are 4 years and less. So you can do immediate spica cast. Immediate spica cast means that you don't have to do a period of traction before the spica cast. You can just put the spica cast immediately, and you can put the whole affected extremity and half of the involved of the other extremity. Like you can see here, I'm putting the spica cast for my patient, and a few technical tricks in this case. Avoid the 90-90. Again, when I was resident, that was the position that we put the patient in, 90-90, 90-degree flexion of the hip, 90-degree flexion of the knee. There were few cases of compartment syndrome that were described with that position. So we're now putting the 45 degrees. So you can see here, this is a 45 degree of the involved hip, 45 degree of the other, and 45 degree of the knee. Also avoid that technique of putting a short leg cast and then using that as a traction, because also this is associated with compartment syndrome, and you can get a compression over the area that you're using as a traction. So to avoid 90-90 and avoid putting a short leg cast and pulling that using as to do the traction from. If you can see here at the here in the chest, I put 2 blue towels, so I'm not putting it tight so the child can eat. And then I usually give very good area of cutting here to provide perineal hygiene for the patient. It's very important because you don't need the cast to go all the way to the private part of the patient. It can be open over the lower part of the abdomen. It will not make the spica cast weaker, but the patient need that so that they don't soil the cast. And also in the back, I take a big part of the cast off so that the family can take care of their children. Remember, spica cast, I always tell my resident, it's not easy procedure. I do it myself. I usually require 3 people to help me to put the spica cast. In order for you to put a good spica cast, you actually need more assistance than in surgery. One has to be holding the child, one has to be holding I usually hold the 2 legs, and then I instruct the people around me how to put the spica cast itself. It's something that is much more involved than most people think. Now let's go for the 4 options for surgical treatment. We'll go through external fixation, flexible nail, rigid nail, and plate and screws. The external fixator, when I was resident, was very common to use for the treatment of femur fracture. It was actually, I think, the most common method of fixation of femur fracture. It has advantage, definitely. It's minimal blood loss. It is relatively quick. And there's less instance of deep infection in cases of open fracture. And you can use it for provisional. If the patient is very sick, you can put it provisional fixation and then later on bring him for another fixation if you plan to. So there is an advantage of external fixator. Like this patient is a good example to put an external fixator. This patient has a tibia fracture and a femur fracture, and you can obviously see this is a bad open femur fracture. The skin stops here. All this part is outside the body. It's a highly contaminated fracture. Patient has other fractures. So this is like a very good indication to put external fixator, and that's what we did here. It's an external fixator applied 2 pins above in the proximal femur, 2 pins in the distal femur, and you can see here the flexible nail for the fractured tibia. And this is a good indication to apply as an external fixator. A highly contaminated open wound, the patient has another fracture that is requiring surgery. You don't want to do an extensive surgery that the patient would bleed, and you would like to decrease the incidence of deep infection. So why are we not using the external fixator as common? It's mainly refracture. Refracture is common if you use the external fixator. It's about 1/5 of the case, which is a very high chance of complication. 20% of kids will get refracture. There is some instance of malalignment, malrotation, and limb length discrepancy, but the main reason that people stop doing the external fixator is the instance of refracture that we see here. Also, of course, the pin tract infection. So the AOS, the American Academy Guidelines, says it's significantly higher complication rate using the external fixator, and it is less desirable than other methods of fixation. So external fixator still has a rule, but not as common as we used to do 20 years and 25 years ago. So the elastic nail. Elastic nails are common, very common method of treatment of femur fracture. Actually, I think it's the most common for kids less than 10 years. So what is the indication to put an elastic nail or flexible nail? It's if you have a transverse with minimal comminution mid-shaft and in children less than 45 kilograms. So if you have a child less than 45 kilos, so he's not big, it's a transverse fracture. You don't want, like this fracture is a transverse with a small comminution here medially, but it's a relatively stable fracture, and it's mid-shaft. You don't want to have it in the proximal and the distal. You can still apply it with certain changes in proximal and distal, but the classic indication is a transverse mid-shaft in a children less than 45 kilograms. You can see here, this is one of my patients. That's like a classic example, transverse, mid-shaft, child is less than 45 kilos. You pull the traction, you apply the 2 pins. You want with the flexible nail to go, that one needs to go all the way to the neck, that one needs to go all the way to the greater trunk to give you the rotational stability. You want to have the spread of the 2 pins at the level of the fracture. And this will give you the enough stability to allow early range of motion. I usually don't put my patients, I actually never put my patients in a cast when I do a flexible nail. I sometimes put them in knee immobilizer. If I think that this patient needs a cast with a flexible nail, I will look for a different method of fixation. I put a flexible nail and a knee immobilizer so the child can have some comfort by not moving the knee for 1 week, and then after that we take the knee immobilizer and allow range of motion, and most of the time we allow the weight bearing after 1 or 2 weeks. But I don't use cast for my flexible nail. You try to get a relatively thick flexible nail to get more stability. So the advantage, it's a very small procedure. It's relatively quick. We do very small incisions, medial and lateral, and then we pass the nail. I pass both nails, and then usually there's one of them. I pass the nail till the fracture end, and then usually there you will see one of them that is aiming more towards the fracture. So I push that, so it doesn't have to be medial or lateral, whatever is the one pointing to the other end of the fracture, and then I pass that one, and then I pass the other one. What is the disadvantage of the flexible nail? It's not very stable. So if you have a spiral fracture, it may shorten, and if you have a heavy child, it may fall into varus. It cannot use for proximal or distal femur fracture. You can do some modification in the technique to be able to do that, but it's not as stable. So we always share the cases that goes good. I'm going to show you here one of the cases that I did that actually didn't go as good. It showed you like this was a bad indication from me to put a flexible nail. It's a highly comminuted fracture, and this child also have a head trauma. So what happened is I decided to put a flexible nail. The kid was only 6-year-old. Despite that relatively large comminuted areas, there is like 2 or 3 pieces here. The contact is minimal, and we put the flexible nail. However, what happened here, so if you see here also the flexible nail were thin, they were not spread, they were not all the way, so there were many technical mistakes that I did in these cases. And you can see the amount of comminution here, and with the head trauma also, this child started to get convulsion. And this was the result. It shortened a lot here. This went here distally, this end went proximally. The comminution, of course, started to go away. The child with his convulsion started to get muscle spasm, and then what happened is the pain went out. So this was a mistake from my side, and we had to do revision with this with doing submuscular plate. This shows you that flexible nail is a good indication, but you cannot use it in every case. Rigid nail. Rigid nail is commonly used now, especially in older children, adolescent. So the difference in the rigid nail is you have screws proximally and distally, interlocking screws that will maintain the length, maintain the rotation, and it can be used especially for children that are older than 12 years. Advantage, it's rigid fixation. It controls the rotation, as I said, with interlocking screws. The disadvantage is that you come very close to the blood supply of the proximal epiphysis. So you have to be worried about osteonecrosis, AVN, in the cases of using a nail, and it can inhibit the trochanteric growth, which result in some valgus into the proximal femur. So this picture here shows you the difference between the entry points. So this is the piriformis entry. So here's the blood supply. You see here the blood from the femur from the back. So this is the medial circumflex. This is the lateral circumflex. So this is the femur from the back. This is the entry. So the entry, the piriformis in children is very close to the blood supply. So you have a chance here of injuring the blood supply to the proximal femur. You can go trochanteric, which is safer. So this is the piriformis. This is the comes close to the medial circumflex. Trochanteric is safer, but what is even more safer is what we call lateral entry. So adolescent nail here that are in the market uses what called the lateral entry. So if you look to this picture here, here will be the piriformis entry. Here will be the trochanteric entry. Here is the lateral entry. The lateral entry is very safe. It's away from the blood supply here. So the lateral entry, so the tip here is the trochanteric, here is the piriformis, here is the lateral entry of the nail, adolescent nail, and all commercial available nails that we use in adolescent have lateral entry. They don't use trochanteric entry. And how do you know, how do you start your entry point? It's a few millimeter medial lateral to the tip, or you can you can judge it with the amount of the angle here, depending of course on the company that you use, and measure exactly where it is. But in most cases you really don't need to measure it. It's I usually go about 6 or 7 millimeter lateral to the tip of the greater trochanter. So you can see here, this is one of my patient. So here is the piriformis entry, here is the trochanteric entry, and then you go 7 millimeter here with your guide wire, and then this will be your entry point for the trochanteric. Usually you need only one screw proximally and 1 or 2 screws distally to maintain your rotation. So we spoke about external fixator, we spoke about flexible nail, we spoke about rigid nail. The last thing is the plate, and you have 2 types of plate, either compression plating, classic, or submuscular plating. This is a nice picture here from the AO that shows you the classic plating, which can be extensive dissection or a little bit limited dissection, or you can go for a submuscular plating, as you can see here with the 2 ends. Let's start with compression plating. So this is a patient, one of my partner patient. They decided to do compression plating regular, and there is nothing bad with this. In most cases, it gives you a good result. There is a little bit higher chance of infection, but not that much. It's still a very good method of treatment, and patients can start range of motion early. This is actually one of my patients that I did recently. So I went in with an intention of do a submuscular plating. However, I failed completely to get the reduction. This piece here, this middle piece, I wasn't able to put it close back. I wasn't able to maintain any reduction. So after struggling for 1 hour, I decided I'm going to go all technique compression plating. I opened all this part here and get the pieces together, and put screws here, fragmentary screws, lag screws, and then I put a plate, neutralization plate over that. So nothing wrong with the classic plating, either compression or you use lag screws and put a neutralization plate. It's still a good option, especially if you don't have a CR. Now the submuscular plating, which is one of the things that I really like. I think it has lots of advantage. So this is a good example, a spiral fracture that goes very proximal in a heavy child. So you cannot really use flexible nail. If you, especially with these who go proximally, it may not be as stable with rigid nail, and also I don't like to use a rigid nail before the age of 12-year-olds. I think the medulla is very tiny, and it may not be easy, and I'm also worried about the blood supply. So in most cases, I don't go to rigid nailing before the age of 12. So this was a good patient for the submuscular plating. I'm going to show a small video on how we do the technique, but here everything is done under C-arm. We do a small incision at the level of the trochanter and another one at the level of the distal femur, and then we measure the plate that will span all the femur, and then we pass the plate from one side to the other, and then we contour the plate so it lies nicely on the femur. You will need 2 areas of contour, one proximally and one distally, for the flare up and below, and then you start putting the screws. In this case, you see we put the threads over the screws, so in case you miss the screw, it does not go to the other side of the femur, and then you waste a long time to try to retrieve it. And you can see here, this is the product here. At the end, you apply screws, regular screws in the beginning, push the plate to the bone, and then get the final product at the end. Submuscular plating, like this is another example. This is a young child here. You cannot really use a rigid nailing. You cannot use flexible nailing. It's too much comminuted. So we apply submuscular plating here. It's a very good, strong fixation. Patient usually can start weight bearing after 2 weeks. You don't need any form of external immobilization. best indication for them, children from 5 to 12, because as I said, after 12, I think rigid nailing may be easier and faster and more biological fixation. Here is one of the patient. Actually, this is the patient that we're going to show in the video. You can see it's a very proximal fracture. She's an 8-year-old female. You cannot use flexible nail. I don't like to use rigid nailing in this young age. So what we did is we did submuscular plating, 2 small incision, and put that nice plate. The patient was able to walk after 1 week. I'd like to put here the video. We're going to show about like 5 minutes, not the whole video here. So this is the positioning. I use a radiolucent table. You need a C-arm. If the fracture is comminuted, I'll actually prep both sides. I put if you can see here, we're putting a small bump under the hip, so I can get lateral easily. The whole limb is draped free, so it's easy for you to do your manipulation. And then we drape. Here is this drape, and we're using the C-arm from the other side. I use put the plate while doing the traction to know the correct size of the plate. I'd like a plate that goes from the greater trochanter to the lesser, from the flare of the greater trochanter to the flare of the distal femur. And then when I like that size plate, I'm going to do the contouring. Once we do the contouring, we do a small incisions here. If you can see, there is about like 2-inch incision distally, 2-inch incision proximally, and then use a cup elevator or a periosteal elevator, whatever you have available, and you go submuscular with the periosteal elevator to make a path for the plate. If you see, every step is under C-arm, so I use the C-arm to be able to find the exact area of the proximal distal femur. And then once we like the plate, we do the contouring. Remember that these plates that span the whole femur actually have a curve on the sagittal plane, so you have to apply them correctly and not reverse. Then we passed here we're passing the plate for you can pass it from any side, from proximal to distal or distal to proximal. It's usually easier to pass it from the area of the fracture. So if the fracture is more distal, you push it from distal. If it's more proximal, you push it from proximal. And then I always, or in most cases, I fix it distally first. Distally, there is less soft tissue, so it's easier to apply the screw. And I put a regular non-locking screw, as you can see here, to push the plate. You can see here the contouring. It's nice. I'm putting this, and then I apply another screw here, approximately regular, to push the plate to the bone, and then this will get your coronal direction alignment. I only apply 1 screw proximally and 1 screw distally, and then I start playing with the lateral view to see. So if you see here, there is some sagging that happens. So in order to correct that sagging, what you do is you put some bump here under the femur. You can see here the lateral view is not 90 degree because you will see the other femur, so it's about 85. And then I extend and rotate like 5 degrees to be 90 degree, and then I put the pillows to get that sagittal correction, and then I add 2 more screws, 1 above and 1 below, and then when I like it now, I add more screws, and this gets you your fixation. This is basically we can stop here. We can go to a new share. This is this is how I do my submuscular plating. And now back to our lecture. So this actually the patient that we presented into that video, and we actually published our result, 60 cases in core in 2013. So let's now sum up. We mentioned lots of methods of fixation. I'm going to give you tips on when to use when. So if it's a stable fixation, If it's a stable fracture, I use pelvic harness or spica cast. So kids that are 4 years and older and younger will have a spica cast. If it's a birth injury or less than 6 months, they can have pelvic harness. So that's easy. Kids that are 4 and younger, spica cast. Now from 5 to 12, if it's a stable injury, meaning it's like a transverse mid shaft, minimal comminution, I use elastic. If it's unstable and the patient is less than 12, I will use submuscular plate. If he's older than 12, I'll use lateral to trochanteric entry. There's companies now that are making smaller nails, so you can go with that 12 to 11 or 10, but I won't go younger than that in most cases. So very easy, less than 4 years and younger, it's a spica cast. From 5 to 12, if it's a stable mid shaft, you use elastic nail. It's a quick procedure. If it's unstable, if the kid is less than 12-year-old, I will use submuscular plating. If the kid is older than 12, I will use lateral entry nail. You can use external fixator in contaminated or polytrauma, and if you don't have a C-arm, you can use conventional plating. So 4 years and younger, spica. Older than that, stable fracture, you use elastic nail. If it's unstable, you can use submuscular plating. If it's younger than 12, if it's older than 12, use lateral entry nail. If you don't have a C-arm facility, you can use classic open reduction internal fixation. If that kid is unstable or highly contaminated, use external fixator. This slide here is very important to guide you to which treatment to use. We're going to go quicker on the proximal and the distal femur. So here is the proximal femur. We all know why it's an important topic, because the possibility of having avascular necrosis. Remember, the more proximal you are, the higher chance of getting avascular necrosis. So if the fracture happens through the physis, which is type 1, it's an extremely high incidence. If it's a transcervical, it is about 70%. If it's a trochanteric, it becomes less. And if it's intertrochanteric here, I'm sorry, this is the basicervical. So this type is like a specific for children. It's called basicervical. And then if it's an intertroch, it's much less instance of AVN. So this is the classification of proximal femur fracture, and it basically helps you about the incidence of the avascular necrosis. The avascular necrosis can happen due to one of two things. It's either like direct injury to the vessel, as you can see here, or it can be because of the hematoma into the capsule that is a compression on the blood vessels. This is a case of proximal femur fracture here. You can see the line of the fracture, and what happened is, so this is a basicervical. So reduction was obtained, the closed method, putting the patient on a fracture table, and then in order to avoid the effect of hematoma, we did aspiration to pull the blood out of the capsule. You can see here blood coming out of the capsule, and after that fixation was done with the screws. If you think that the screws are not enough, you can add the spica, or you can of course better put a plate like a dynamic hip screw that is pediatric, or one of the new proximal femoral plate if you have an anatomical one. If you don't have except screws and you don't think it's a stable, of course you can add spica cast for the first few weeks. This is another patient here. This is a trochanteric fracture. This was open reduction internal fixation using pediatric dynamic hip screw. This is one of the patients here that I had recently. You can see she has a proximal femur fracture, basicervical, through a simple bone cyst. So we did also the same thing. I didn't have at that time anatomical plate, so I actually used one of the valgus plate and I pushed it back a little bit into the anatomic range. So this was actually a valgus plate. So this was like a 150 degree. and I contour the plate to become less bulbous. And as you can see here, we applied some bone graft into the simple bone cyst. In this case, because there was basically no bone here, it's a cyst. I thought that if I stop here, I'm not going to have any fixation. So the plan is we pass the screws across the epiphyses, across the physes. And as soon as you get the healing, you remove these screws. There's companies now that started to make pigs. It means like screws that are smooth in the distal part. So if you have this, you can use it. If you don't have it and and the fracture is very proximal, or as in this case, you have a simple bone cyst that you don't have basically any fixation into your proximal femur, you can definitely cross the physes and tell the family that as soon as you get the healing, you will remove these screws to allow the patient to go back again. Now let's talk about distal femur fracture. There is three main types of distal femur fracture. The minimally displaced supracondylar fracture in infants. This is a common fracture to happen in infants and toddlers. Minimally displaced, or sometimes it's even buccal. Or physeal injury that happened through the physis, or metaphyseal injury that happened through the metaphysis. So these are the three types of the distal femur fracture. The anatomy here is important. Remember, the distal femur physis is the most active physis in the lower extremity. It's about 1 centimeter a year, so it's very active. And the physis in the distal femur is not straight. It actually has, we call it mammillary bodies, so it goes up and down. So that's why when you get an injury, most cases, if you have a physeal injury, it goes through the provisional calcification, which is a layer in the hypertrophic zone. But in cases of femur, it actually will go through multiple zones because of the shape of the physis. That's why it's very non-forgiving. About 50% of cases of distal femur fracture that happen through the physis will result in injury to the physis, either a fusion, complete fusion, or partial fusion leading to deformity. It fuses around the age of 15-year-old in boys, 15 to 16, and 14-year-old in girls. We'll speak about the minimally displaced supracondylar fracture. As you can see here, another case. This can be associated with child abuse, as we said before. And you can put a spica cast, or even sometimes if it's a very distal, you can apply a high above knee cast. That should be fine. Sometimes you can even apply a high above knee splint. It doesn't have to be high above knee cast, and that should be more than enough. In 2 weeks, it should be completely healed. The physeal injury, these are high energy injuries. Most of them are type 2, and you have to keep an eye on the popliteal vessel. Remember, the popliteal vessel are very close to the physeal injury. So if you have, especially the extension type, it may be injured with fracture, as I'm going to show you some pictures. As we said, there's 50% chance of growth disturbance. So this is one of my patients here. She had a physeal injury here, if you can see, obviously here into the left femur. When she was young, she presented to me with a 5 centimeter difference. So we had to apply lengthening for her in order for her to get that 5 centimeter. The highest instance is Salter-Harris type 4. The lowest instance is Salter-Harris type 1. Collectively, it's about 50% chance of growth disturbance, highest in type 4, lowest in type 1. Very important that you have to examine the neurovascular bundle. This is the most important fracture in the femur to assess the distal bundle. Try to get, especially if there is compression or you think it's highly displaced, get an urgent close reduction versus open reduction. And then the fixation depend on the type of the injury. If you have enough area, if it's a type 2 and you have enough metaphyseal area, you can put screws parallel to the physis. If you don't, you use a smooth K-wire across the physis. We're going to show some examples for that. So you can see here the fracture here, the proximal femur extended here all the way. And this, of course, is putting compression over the popliteal vessel. It's an open injury. So this needs a urgent close reduction. You don't have to delay this for arthrogram. This is a CT angio that was done in our institute. They do the CT angio very quick. But if you think it's going to delay, you don't have to do this step for sure. You can see here the bundle, it was not injured, so the patient was very lucky. It's very close to the fracture end, however, no injury happened for this patient. And he was treated with, as you can see here, smooth wires. You have two options, like this is the option number one. You can apply the smooth wire this way and then apply the cast over it, or you can apply it and then push it to the end and then pull it from the proximal and leave it short here into the bone. And the idea of this is because these pins get pin tract infection more than others because of the soft tissue in the femur. You'd like to keep them away from the joint, so if in case they get infected, they don't cause septic arthritis. You can see here another example. This is type 2, but the metaphyseal part is very small, so you cannot really put a screw into this area. It would be very poor fixation. So what we did is we applied the wire. So we applied the wire as regular here from distal to proximal, but then we passed the wire all the way from the skin, and then we used the power to pull the wires from here and here, and we stop here outside the joint, so that if something happened in these pins, they are not leading to septic arthritis. You can see here the reduction here and here, and you can see the pins here proximally and the splint over them. If you have a relatively big piece here, or like type 2 with a big metaphyseal, you can fix them with the screw parallel to the physis. And in this case, you don't have to cross the physis at all with the smooth wires, as you can see in this example. This is another example. Also, this is a relatively big piece. I usually get a CT to know exactly if it's more anterior or posterior, but you don't have to. And then here is the reduction. You can see we have perfect reduction here with 3 screws from metaphysis. So this is a good fixation. You can only apply knee immobilizer, and you spare the physis. You do not have to go through the physis in this case. For metaphyseal fracture, you can apply plates that has screws that goes different direction. I usually use the proximal humerus plate. I think it has, because it has lots of angles, you can obtain many points of fixation distal to the fracture. And we actually published that, I think about 6 or 7 years ago in Journal of Knee Surgery, using the proximal humerus plates for the distal femur. You don't have to use, you can use other plates to fix. However, I like the proximal humerus because it has many fixation options. I flip the plate, so these fixation options will be distal to the fracture here. I'd like to conclude with this case. This is a patient, so he presented the dirt bike. It's like a motocross, and you can see here the fracture. He has a femur fracture, he has a patella fracture, he has comminuted distal femur fracture. You can see the CT also, see how the amount of the comminution here. So we did a submuscular plating for him proximally and open reduction internal fixation here to obtain anatomical reduction into the joint part, and to obtain indirect reduction of the metaphyseal part. He healed excellent, and he had very good range of motion. Of course, he ended with 5 centimeter limb discrepancy, so we had to stop the growth of the other side. This is the affected side. This scar here was a soft tissue. This is the area that had the injury, and you can see here the end result with 5 centimeter difference. Thank you. I'd like to thank all of you for listening to the lecture, and again, I'd like to thank Dr. Copeland for inviting me, and I'd like to thank Orthopaedic Principles.
Thank you, Amar. That was a splendid lecture. You've covered almost everything about pediatric femur fractures, and I'm sure no one is going to have any doubts, but still there are a few who have written me questions. I'll just go through some of them. One is regarding pediatric femoral shaft. Is there a difference between using a double hip spica versus a 1.5 hip spica versus a single leg hip spica for simple pediatric shaft fractures in less than 6 years?
Yeah, so the studies. So I don't think you have any reason to use double spica. It doesn't help you with anything. The single leg, there is a good studies that it allows faster healing. I don't trust it that much, so I don't use it. But there is definitely, if you'd like to use it, there is good studies that it's not associated with more malreduction. But I still don't have the courage to use it. I still use the classic 1.5. I don't think that full two will give you any advantage. So I use only the 1.5. There is some advantage for using single leg spica, but I'm always worried about that the child will lose reduction and the family will not have.
Okay, thank you for that. And the other question is there a role for the traditional Barlow's traction? You have seen that kids are, the legs are lifted up. That one, is it still relevant or do you use it?
I remember, so I actually have very bad experience with the Barlow because I was a resident when we used the Barlow and we hang the kids into the ceiling, and I saw two patients that actually lost their toes from vessel injuries that happen. And the problem also, it's now you don't. It's very expensive to admit patient to the hospital for a long time. No insurance company and the patients, even if he doesn't have insurance and he's paying out of pocket, like I don't think there is any advantage for that. Especially for me, I'm biased because I saw two major complications from Barlow's when I was resident, so I don't use it. I don't think there is any indication for it.
Even I have my experience is not good with Barlow's because when the moment you put kids on Barlow's, it is a very difficult appearance, a sight. It's
Correct.
hard for the parents to accept it. That's what.
Correct. There is the problem that there is a picture for a child smiling in with a Barlow, and this picture I think is very deceiving. I never see that child. I saw the Barlows. We used to use it when I was resident. Uh, the child is never smiling, and the family, as you said, they're not smiling. No one is smiling with Barlow's traction.
Only the surgeon would be probably smiling for some time and later he stops smiling. Okay, so that was one. And the other question is, uh, what is a role for, what is a typical patient where you're going to do a submuscular plating?
So the typical one. So the problem with submuscular plating is I would say it has a learning curve, so it's not very easy. So I wouldn't use it for if I can use a flexible. So if I have a stable fracture, mid shaft, transverse fracture, I will definitely use flexible nail. It's much faster, much easier. If I have a child that is, I used to use 12, now I use 11-year-old and older, I will always use rigid nailing. So it is that child which is between 5 and 10 that has a very unstable fracture that goes all the way proximal or all the way distal, or a very long spiral that goes very close to the lesser troch. I will use the submuscular plate.
So it basically comes down to a patient within 6 to 11 years who is not a very good candidate for a flexible nail.
Correct.
Okay.
Excellent. That's it. Yeah.
Okay, so what about the degree of comminution? Suppose there's a lot of comminution, it's not an extension I'm talking about, a lot of comminution in the mid shaft, like one of the pictures you showed. Do you think a submuscular plating gives a better result than a flexible nail?
I think so. I mentioned quickly there is some techniques that they now put. There is something called screws that goes over the flexible nail. They said it gives you more stability. I think if you have a highly comminuted fracture, the one that I showed, that they put the flexible nail and then the child started to get convulsion, I don't think even with putting the screws you will obtain enough stability. I think if you have a small butterfly, that the very first example for the flexible nail, it's still okay. But if it's a comminuted fracture, uh, I think the only way to put a flexible nail is to add a spica over it. So I wouldn't. You still can do it if you think, again, the flexible the submuscular plate has a learning curve. So if you don't want to do a submuscular plate, you want to stick to flexible nail, you can put it with comminuted and then add the spica cast over.
Okay, you can protect it with the additional spica.
Correct.
Okay. Well, and the other one is, what is do you have any experiences in anterograde flexible nail? For example, a subtrochanteric fracture, have you used a antegrade
Yes.
flexible
So
nail?
if the fracture is very distal, I actually have a case that I did about 1 year ago. It was a very distal fracture. I was thinking of putting it, but I didn't put it. It's my mistake. I'm sorry. You can definitely go, and then you go with from the greater trunk, and then you turn one of them to be aiming towards like a C towards the lateral, and then the other one like an S and goes medially. But you need to spread them. You cannot have both of them going from the trunk and ending in the lateral distal. One has to end lateral distal, one has to end medial distal. And it is definitely a good method of fixation if you're having a distal fracture.
Okay, so you mean to say you're going to put two antegrade nails, right?
Correct. Two antegrade nail from the greater trunk, one shaped S, one shaped C.
Okay. What about, suppose you have a pediatric subtroch and an 8-year-old kid, and can we put up antegrade one and one retrograde?
Uh, you
Proxy-
can. I'm not sure about the advantage of it. I think I
Because what I mean to say is, suppose it's a proximal subtroch, you put an antegrade from the lateral, you
hmm?
go along the middle and comes back to the lateral, like a C. So you
Okay.
get a 3-point fixation. And
I
then
think you
go,
can.
and you can go distally. The second nail you
Uh,
start in distal medial, and you
uh,
come the other way around.
yeah, I think you can. I didn't do it, but I think you can. I never did that, but I think you can.
Technically possible, right?
Yeah.
Okay. And the other one, there was one more question is, do you have any experience with a pediatric shaft going into avascular necrosis? I mean, the head going into the avascular necrosis.
Yeah, I had one transcervical that ended with some avascular necrosis, but it was limited to the part of the neck. So usually it's not as bad as the AVN that you get with DDH, and it's usually not very extensive. It was a proximal femur transcervical fracture. It's not as bad as the one that happens with DDH, at least the one that happened with me. Proximal femur fracture, they're not as common. Like we used to get only 2 a year, and most of them are basicervical and trochanteric, which has, especially now we take them in even in the middle of the night. Their chance of getting AVN is very much less.
Okay, so you mean to say if you have a femoral neck fracture in a kid, you're going to do surgery as soon as possible, right?
Yes, I take them in the middle of the night. I don't wait. Usually by the time, because we're tertiary center, by the time they come to us, it's about like 8 or 9 p.m. I take them midnight. I don't wait till the next day.
Okay. And do you do any capsular aspiration to reduce the tamponade effect?
Yeah, if I'm doing closed, if I'm doing open, of course I'm opening, but if I'm doing closed, we put the picture of the big syringe. You put a spinal needle, 16 gauge or 18 gauge, and then you put it under the C arm over the anterior neck, and then you pull the blood to decompress the capsule, because we don't know if the AVN is happening because of the compression or because of the direct injury to the vessel. So I think it makes sense that you have to aspirate if you're doing it closed.
Okay. The other one is there any flexible intramedullary interlocking nail available in the United States?
No. Flexible interlocking, no.
No,
Do you
right?
have one here in India?
No, because someone sent me a picture with a flexible nail, like an interlocking coming from the greater trochanter, but with screws options.
Oh, no, I didn't see. So what there is Facedoval nail, but that's not flexible. That's still rigid. Their new nail has it's not a screw. They have a hole that you can put a wire in it. But I didn't see other things. I didn't see a flexible that.
Okay, there are no nails where you can put a screw through it.
No, no, I didn't see that option. I don't think it's commercially available.
Okay, because someone just sent me a picture and just asked
Yeah,
me, okay, is such a nail available? Because
no.
he has seen from I don't know from where he saw that he has not
Yeah,
mentioned.
maybe it's in Europe. I don't know.
Yeah, okay. So I think there are no more questions, Amar. And thank you for your splendid lecture. I mean, you've
Thank
covered
you.
everything on pediatric fractures, and I would recommend everyone to go to Dr. Amar's YouTube channel, Pediatric Orthopedic channel, and Orthopedic Board channel as well. That helps you to prepare for the American Board of Orthopedic Surgery. He's done splendid work, and I'm sure it's going to benefit a lot of people. Thank you, Amar, once again for
Thank
us,
you. Thanks for the invitation. Thank you.
and we look forward for more from you.
Thanks. All right.
Thank
Thank
you.
you.
Yeah.